Hi, everyone, and welcome to the inaugural issue of the Weatherhead Forum for the academic year 2021. The Weatherhead Forum showcases the research and debates of the various units and affiliates of the Weatherhead Center for International Affairs. As with everything else in our lives, this year the forum is a little bit different. And we have in the past included presentations by research groups. We will be doing some of that. With this mix, we hope to explore the work of our research groups, and we'll also be mixing it in with some special sessions. This event is one of those special sessions. A few housekeeping items. The session is being recorded for eventual posting on our website. Please, if you have questions, type them into the Q&A feature on Zoom. We will collect the questions for the panelists, and they will address them during the Q&A period after the panelists have each presented. With that, it is my pleasure to introduce the chair of the session, Michelle Lamont. Michelle is the Weatherhead Center Director. She is also the Robert I. Goldman Professor of European Studies and a Professor of Sociology and of African and African American Studies in the Departments of Sociology and African American Studies at Harvard University. I am happy that you're all here, and Michelle, over to you. Thanks.
Thank you very much, Ted. It's a pleasure to welcome everyone. It's a bizarre way to welcome everyone in this academic year. This is the first public event of the Weatherhead Center at large. As Ted mentioned, this Weatherhead Forum normally under normal conditions meets every 2 weeks. And this year we've decided to lighten the program a little bit to make sure that we don't all die of Zoom fatigue by December. But given what has been happening, of course, we decided to dedicate this first session to the COVID crisis. And since we have 230 faculty affiliates, a number of them are leading experts in the field of health. So I've decided to tap our very influential colleagues who have been dealing with many concrete issues at the ground level over the last few months to talk to us about their experience and their thoughts. So this session is titled Thinking the Future, New Perspective on Globalization and Health under COVID-19. To give the session a special twist, I asked a fellow sociologist whose work I've come to appreciate a great deal, and Mische, who is an associate professor of sociology and peace studies and faculty fellow at the Kellogg Institute for International Affairs at University of Notre Dame. I asked her to join us because she's been doing some of the most influential work on this growing and very exciting literature on, how we think about the future. And the question of how we project ourselves into the unknown in the context of growing uncertainty, it's very important that we understand better the tools that exist out there to try to make sense of this experience that we are now having collectively and individually, and the impact on our, on how we experience the world. So she will open the conversation with some of her, research on the topic. And then we have 4 faculty associates of the Weatherhead Center, each extremely influential in their own realm, but some of them have been teaching with one another for several years. So it's also a group that has been in conversation with each other and that I've gone to appreciate a lot. So the first speaker is Vikram Patel, who came to Harvard a few years ago from LSE. He is the Pershing Square Professor of Global Health and Wellcome Trust Principal Research Fellow in the Department of Global Health and Social Medicine at the Harvard Medical School. And he's also professor in the Department of Global Health and Population at the Harvard T.H. Chang School of Public Health. So he is Mr. Global Mental Health, and I'm very excited that he can join us today. Second, we have my old friend and dear friend, Allan Brandt, historian of science. Amalie Moses Kass, professor in the history of medicine at Harvard Medical School and professor of the history of science in FAS. and he is now working on stigma. So I really look forward to learning more about his current projects. The author of a very influential book on the smoking, the end of the smoking industry. Paul Farmer is the Kolokotrones University Professor and Chair of the Department of Global Health and Social Medicine and Professor of Medicine at the Harvard Medical School. I think we're all familiar with the important work that he's been conducting on health in Haiti and a number of other contexts, extremely popular Harvard faculty. So thank you, Paul, for taking time to join us. And last but not least, Arthur Kleinman, also an old friend who welcomed me at Harvard when I arrived here in 2002. And he's the Esther and Sidney Rabb Professor in the Department of Anthropology and Professor of Medical Anthropology in the Department of Global Health and Social Medicine and Professor of Psychiatry at the Harvard Medical School, world-renowned for his very important work on mental health in China. And he's going to talk to us about his more recent work on caring. So each of them are going to have roughly 15 minutes to make a presentation. And then we're going to have a short conversation between them before we open the Q&A. And so let's get started. Thank you very much, everyone, for joining us. We have now 119 people online listening, and the talk will be recorded, so also available for future reference. So Anne, the floor is yours.
Thank you. Let me just share my screen. Okay, so I am starting off this panel as the only one of this distinguished group that is not an expert on global health. Michelle asked me to share some reflections from the standpoint of a cultural sociologist who studies the role of future thinking in social and political change efforts. I spent the past several months engaging with self-described futurists or foresight experts, as they have struggled to make sense of this period of disruption and upheaval that has been triggered by the global health crisis. I say that this has seemingly been triggered by the global health crisis because this all hell breaking loose year, where only 2/3 of the way through, owes its rippling effects to the fact that it's coming on top of many other simmering crises with different time horizons, different degrees of urgency, and different lines of causality. These crises are also accompanied by contending narratives about how these events are transforming the world. So as I was writing up these comments, I thought back to that Tuesday in early March in that hush before the storm. I remember commenting with friends on social media that Tuesday night that everything's very weird right now. We didn't know what we were waiting for at that time. Was it primary election returns, school closings, the onset of fever, economic crisis, climate catastrophe, or the collapse of democracy? My university shut down the day after that, I think a few days after Harvard. Local school shut down the day after, and we all plunged into interrupted time. A few months later, just as quarantine was starting to seem normal, we were interrupted again by massive uprisings for racial justice, which were hoped to acknowledge here in our work today. So as a scholar, this was doubly strange for me, since what was interrupted was a sabbatical year in which I was working on a book on the use of scenario methods and other foresight tools in international interventions or transnational interventions related to democracy, development, peace building, and climate change. In fact, I had just written a chapter on how to understand scenario work in the light of sociological theories of uncertainty, disaster preparedness, and transformative events. All of a sudden, the cultural dynamics I was writing about were unfolding in a breathtaking way. So as I coped with my own feelings of confusion, fear, loss, and dismay, I noticed an excited, almost giddy response from many of the futurists that I follow. I began attending some of the many webinars produced by foresight think tanks and consultancies on how COVID-19 is transforming our world. I also began to collect journalistic and pundit commentaries, and I wrote a few myself. I knew that this flurry of interpretive work was right on schedule. Sociologist Robin Wagner-Pacifici has written about this process in her recent book, What is an Event? By events, she refers to highly disruptive, chaotic, disorienting, high-stake clusters of happenings, such as terror attacks, pandemics, revolutions, economic crises, or other world-shifting upheavals. These life and death disruptions seem to come out of nowhere, and often, although not always, transform social relations and institutions. She describes what she calls the restlessness of events, the fact that they're always on the move, they're fluid, open, and subject to contested processes of interpretation and reinterpretation. So while there's more to be said theoretically about these cultural processes by which we try to stabilize and make sense of events, I'll leave that discussion for a different audience. My challenge here is to bring a few points home that can set up a conversation about how to think the future of the global pandemic. First, just a quick word about my own work. In researching my book, I've collected hundreds of public interest scenario reports from around the world, addressing problems ranging from civil war to the future of democracy, climate change, food insecurity, energy use, healthcare, women's rights, global governance. While there are many different kinds of scenarios, for the most part, this work attempts to come up with multiple plausible stories as a means of reframing possibilities in the present. Now, in many of these projects, there's a disclaimer like this one. This is taken from a very interesting national scenario project in Kenya in 2000. These practitioners of these scenario methods insist that they are not doing prediction. Scenario is not a prediction. We're not saying that these things will happen. While there may be a few pundits out there willing to make strong claims about what will happen in the future, most self-respecting foresight experts insist that this is not their job. Literally, every report that I have read has a disclaimer of this sort. They see their job not to explain what will or even should happen, but to think about what could happen using the various foresight tools at their disposal. These include not only scenarios, which are narratives or stories about the future, but also signal scanning, trend analysis, world building exercises, and the creation of headlines, personas, and artifacts from the future. These tools are ways of engaging uncertainty, exploring multiple narratives, and peering around corners with attention to surprises, wildcards, and complex system effects. Now, one methodology that developed by futurist Jim Dater focuses on scenario archetypes, asking people to imagine futures involving growth, constraint, collapse, and transformation. Imagining multiple futures, they claim, allows us to see these futures as elastic and flexible. We engage in foresight not to predict, they say, but rather to help us steer through the uncertainty towards the futures we want and away from those we don't want. Hence the futurist excitement that the whole world suddenly has been plunged into heightened awareness of the deep unsettledness and the multiple possibilities of our times. Their services are needed now more than ever. At the same time, ironically, their services are sort of redundant. The experiences of the past 6 months have primed us all to think about how our world and our futures are changing. But we bring varied authority and resources to the task. And my colleagues here bring especially important insights due to their long work in the trenches of global health. But before turning to these insights, I want to put 4 dilemmas on the table related to the foresight endeavor. Despite the somewhat contagious excitement of the futurists, foresight is really hard. But why is it so hard? I think there are at least like 4 dilemmas that we should think about that I think are relevant to our discussion. Prediction doesn't generate uncertainty. Second is the dilemma of preparedness. When we are actually successfully prepared, our work often seems exaggerated. Crisis diagnosis can foreclose careful technical analysis, and sometimes in transformation steers uneasily between intentional action and unintended consequences. So let's take each one of these in turn. To this audience and to anyone engaged, I'm sure, in public health modeling, this statement will not be a novelty. But as a cultural sociologist, I've been surprised by how often, again, here's this disclaimer again, how often scenario practitioners need to repeat this disclaimer that scenarios are not predictions. I know that whenever, as a cultural sociologist, I know that whenever a phrase like this gets repeated so insistently, it marks a trouble spot, a place of ambiguity and tension. So the scenarios that I study are mostly narrative constructions of plausible futures, but similar trouble spots and disclaimers apply to statistical and simulation modeling, including the modeling of disease trajectories. In fact, one of the big debates in the immediate aftermath of the Great Shutdown was, why had we not seen this coming? To many of us outside of the public health field, the pandemic seemed to come out of the blue. Why had it not been predicted? How had the experts missed this? To which the rejoinder was, they had not in fact missed this. Repeatedly, the government was warned that a public health disaster of this magnitude was possible. Simulations by the Obama transition team in 2017 warned the incoming Trump administration of the possibility of a deadly flu pandemic, as did the administration's own 2019 Crimson Contagion scenarios, in which 500,000 Americans died from a respiratory virus that begins in China. US intelligence agencies warned the National Security Council in early January about the dangers of COVID-19. And there were urgent warnings from within Trump's own administration from late January through February. Important investigative reporting in major news outlets has presented evidence that the spread of the virus was not only predictable, but in fact it had been predicted, but these warnings were suppressed, ignored, or acted on with dismay, with delay. So political criticisms aside, this would seem to defend the possibility of prediction. Yet as the country shut down in March, debates over the value of predictive modeling seemed to amp up. How many deaths were we looking at? Was it 5,000, 2 million? The admission late in March that the death toll might be as much as 100,000 galvanized the administration to support a more extensive shutdown. But this was far from a consensus. A weekly survey of experts around that time by Thomas McAndrew at the University of Massachusetts predicted a wide range of probable death tolls from 19,000 to 1.2 million, settling in at about 200,000, a number that we are clearly on track to reach. So why is prediction so hard? Because, as many experts and commentators have noted, models are not crystal balls. They're not even predictions, really, they're scenarios. They offer a range of possible futures based on varying assumptions and inputs, including uncertain knowledge about disease and human biology, the means of spread, the affordances of institutions, patterns of network connection, and the complexity of human behavior. Often models project from past examples or current trends, which can be problematic in dealing with a novel virus. Moreover, models keep changing as our understanding and as behavior patterns change. As Kelsey Piper noted in Vox's Future Perfect blog, predictions are just best guesses about what set of assumption will play out in the future, and even experts don't have a particularly good track record of being right in those guesses. But perhaps prediction isn't the point of these models after all. A very thoughtful commentary on the limits of modeling came from communication scholar Zeynep Tufekci, who noted in an Atlantic article that models aren't supposed to be right. Rather, they're useful to the extent that they support agency and decision-making. We use models, as she says, to identify and calibrate our actions with the goal of shaping the future. We do that notably by being attentive to worst-case scenarios. As she says, by pruning the catastrophic branches of a tree of possibilities that lies before us. However, this focus on worst-case scenarios leads to a chronic problem with scenarios, bringing us to our second dilemma. The perverse logic of successful foresight work, at least that branch of it that focuses on preparing for disasters, is that the action it inspires to avoid worst cases can erase the evidence of its own utility. Zeynep Tufekci pinpoints the second dilemma in her Atlantic article when she observes, When an epidemiological model is believed and acted on, it can look like it was false. These models are not snapshots of the future. They always describe a range of possibilities, and these possibilities are highly sensitive to our actions. Now, the kind of opposite problem appears when a worst case scenario appears to come true. Foresight practitioners can gain predictive legitimacy for having foreseen a negative future, even when their purpose was to steer away from that possibility. Now, this happened in one of the foresight projects, one of the scenario projects I studied closely, the 2000 Kenya at the Crossroads scenario. Now, they came up with 4 stories for Kenya's future, some negative and some positive, and these stories weren't really much heeded by policymakers at the time. But 8 years later, when Kenya plunged into post-election violence, it appeared to many that their worst case scenario, the El Nino scenario, had come true. Now, while the group gained some public credit for their prescience, it also made them sad. The purpose of the scenario building exercise had been to steer the nation away from that catastrophic possible future. This observation is echoed in Andrew Lakoff's brilliant study of preparedness regimes for global health emergencies in his recent book, Unprepared. Lakoff notes that the possibility of unprecedented, Lakoff notes that the inadequacies of traditional statistical forms of risk assessment when dealing with the possibility of unprecedented, unlikely, but highly catastrophic events, such as novel disease outbreaks or other kinds of disasters. He distinguishes between 2 kinds of logics: the precautionary logic, in which we decide that we may not be able to prevent catastrophes. The precautionary logic, in which we try to prevent the disaster from happening, and the preparedness logic, in which we decide we may not be able to prevent catastrophe, so we need to invest our efforts in preparing to mitigate the destruction should it occur. This logic of what Lakoff calls vigilance for unlikely but highly destructive events catches experts in this dilemma. It's hard to know during the outbreak of a new disease just how bad it will be, and thus it's best to be prepared to deal with the worst case scenario. However, if the worst doesn't happen, and it very well may not, especially if we are prepared, policymakers may be accused of exaggerating the dangers and possibly of diverting scarce resources from other critical population needs, such as building public health infrastructure. This happened, for example, when the WHO was accused of overreacting to the 2009 H1N1 epidemic. Lakoff cites philosopher Hans Jonas to note the unfairness of these accusations. The prophecy of doom is made to avert its coming, and it would be the height of injustice to later deride the alarmists because it did not turn out to be so bad after all. So this brings us to the third dilemma. Diagnosing things in terms of crisis can sometimes get in the way of really understanding them. Discussions of crisis are emotionally and politically satisfying, as they speak to the feelings of disruption and deep wrongness of our current moment. This is true for academics as well as ordinary people. For example, in 2018, the Comparative Historical section of the American Sociological Association held a mini crisis on the crisis of history and the history of crisis, perhaps in panicked dismay at recent events in the world back then. Little did they know what was coming a couple years later. One of the key questions at the closing plenary was, what do we do when our theories no longer seem to guide us? How do we make sense of eventful times in which our general predictive theories for understanding and acting in the world no longer explain the fast-moving changes around us? One of the theorists discussed at the mini-conference was historian Reinhard Koselleck, who noted the strong connection between the concepts of crisis and critique. Crisis narrations tell stories about the present that highlight both a rupture with a historical past and a difference from a morally desirable future. They focused attention on the transformative potential of the current moment, as well as the urgency to act to avoid catastrophe. Koselleck argues that the idea of crisis gives origins origins to the consciousness of history itself. However, it can be problematic to jump too quickly to crisis narration. In a provocative recent book, anthropologist Janice Reutemann notes two problems with crisis narration. First, we often slide too easily into moralized accounts of crisis, which tend to overlook the ways in which these are grounded in politics and institutions. Second, she argues that the non-reflexivity of our crisis accounts, the speed with which we jump to them, forecloses certain possibilities for understanding and action. The moral and the teleological impulse underlying crisis narratives, the assumption of error, whether through moral deficiency, political oppression, or systemic breakdown, can preclude the detailed processual analysis of the practices through which things unfold. As she says, a crisis is claimed, but it remains a latency. It's never explained because it's necessarily further reduced to other elements, such as capitalism, economy, neoliberalism, finance, politics, culture. Crisis in this way is an observation that produces meaning. So this is not to say that we are not in a crisis right now. It's a call to not be seduced by our real moral and political urgency from careful and systemic analysis of how the pandemic and related ripples and interactions is unfolding. This means taking into account not only disease transmission and healthcare delivery, but also social, cultural, and political processes. So finally, I'll end with a few closing thoughts about the ubiquitous discourse of transformation. Now, the antidote to crisis narratives does not lie in sturdy sociological accounts of institution building or social reproduction, but rather in prospective stories of transformation. Now, we can find talk of transformation everywhere, from social movements to corporate strategies, to spiritual self-help books, to global philanthropies hoping to address the world's urgent, the planet's urgent problems. These accounts of transformation are what generate the above-mentioned excitement from the futurists. Futurists hope to use their tools not only to prevent disaster, but to help people and organizations respond creatively to emerging opportunities. This is where the enthusiasm can be, well, kind of disconcerting, even when these optimistic scenarios are tempered with those that predict various forms of societal collapse. In this sense, some scenario work has a feeling of kind of hedging one's bets, whether the very good thing or the very bad thing happens, or something in between. We can be seen as having foreseen those possibilities. There's more to say here than I have time for, but I'll just offer one final thought. The optimism about human agency amidst periods of upheaval needs to be tempered by the attention to the interplay between human intention and unintended consequences. The best scenario work, both quantitative and qualitative, pays keen attention to unintended consequences due to complex system interactions, emergent events, and just the things we can't know. It would be a mistake to emerge from these exercises with a hyped up feeling that we are at a crossroads and that we can choose and create our own future. If we use foresight to help steer toward a desired, or at least a less bad future, even at the risk of erasing the evidence of its own success, we must maintain a sense of humility and wariness regarding the whole endeavor. Foresight is valuable. In fact, it's critical, but there is so much that we just don't understand about the world right now. Especially when we think about all of these complex forces that are just like, rollicking through these multiple interlocking systems that we're trying to understand. And with that precaution, I will turn the floor over to my colleagues to share their own insights about where they think we may be heading.
Thank you very much. This is a wonderful opening. And now, with the hope of gaining a little control over reality, we turn to 4 experts on health. Hopefully, they'll reduce the sense of uncertainty that we all experience. So Vikram, the floor is yours. Or should I say the floor or the screen? The screen is yours.
Thank you, Michelle. I'm not so sure whether you at least speaking for myself, I don't know if I'm going to add any more certainty to this incredible event that is unfolding around the world. Anyway, thank you very much for inviting me, Michelle. I'm speaking to you from my home in India, where I have been locked down since I spoke to Paul, my department chair, in mid-March. Seems almost a few years ago now. Asking whether I should get on a plane to return to Harvard to do my spring 2 semester course. And he gave me good advice, I think, then, that I shouldn't get on a plane because there was a strict travel guidance that I shouldn't. And of course, subsequently, India locked down. And so I've remained here now since then. I'm still hoping to return by the end of this month, but I'm going to speak to you really from my own personal experience of the pandemic, very, very local to my last 6 months in India. And I hope that illustrates at least one aspect of the global context in which this pandemic has occurred. So I want to start with March 24th. At about 8 o'clock in the evening, my family, my wife, my son, and I clustered around the television in our home because we were warned that the Prime Minister of India, Narendra Modi, was about to make a major announcement. And so we sat around with our food in our hands, expecting some kind of positive news. Except to our horror, he announced, like a school teacher might to a group of misbehaving children, that the country would enter into a complete and total lockdown in about 4 hours after he spoke. That is to say, he spoke at 8 o'clock in the evening, and he said on midnight, at the hour, the country would enter a total lockdown. And he invoked a very ancient Indian scripture, the Ramayana, where he spoke about the Lakshman Rekha, which literally means, in modern English, a kind of a divine boundary around your house that you should not cross. And for most Indians who believe in the Ramayana, this was almost a divine statement that leaving the house would lead to immediate death because of this terrible virus that was lurking in the environment. Of course, we had been told for many weeks that we shouldn't be stocking up at home because there was no need to stock up at home. And suddenly we were faced with the reality that there would be no food in the house for the next 3 weeks. So my wife, son, and I immediately dropped our dinner plates and got into our car and decided at about 9 o'clock at night to rush up to the local stores to pick up whatever food we could. When we got to these stores, we found massive queues of people lined up outside. And so we dropped each of us at a different store, hoping that one of us would get in before everything ran out. And of course, as I was standing outside one of these stores, in a very surreal, it was almost like being in a film, a police van pulled up, and within seconds, everyone in the queue was darting away, and the police were essentially using large sticks, which we call lathis in India, to beat up people who were standing outside the store to get food. I was, of course, a good upper-class academic who'd never encountered anything even remotely like this. I just stood frozen to the ground. The policeman actually saw my stance and realized maybe I wasn't someone that he should try beating up. So he came up to me and he asked me, he said, why are you not running away? And I said, I have no idea why I should run away. I'm standing here to get some food for the next 3 weeks. And I have no idea why the others have run away. He said, well, there is a lockdown. I said, the lockdown starts at midnight. It's only 9 o'clock at night. He said, no, we in this state have decided the lockdown starts now. And so you have to return right now. I witnessed for the first time, firsthand, how a public health emergency was converted over a matter of a few minutes into a law and order problem, with the police and in some parts of India, the army unleashed to lock 1.3 billion people into their homes, devastating the livelihoods of tens of millions. For the majority of people in this country do not have salaried jobs. They live day to day as daily wage workers, bringing all essential services, including public transportation and all healthcare, to an abrupt halt, and in effect, paralyzing the entire country like never before in its history. For me, it's a very surreal time. I've watched the lockdown, written a lot about this in the Indian press and also in academic journals. But I think for those of you who watch the events in India and indeed in many other countries, including in Africa, The consequences of this draconian policy, this sledgehammer policy, were visible to the world. For even as India has failed to control the pandemic, it is in fact now the epicenter of the pandemic in the world, it has also succeeded in devastating its economy, and it has demonstrated its utter disregard and callousness towards its teeming population, which has struggled for a decent life for decades. Who can ever forget, and I certainly will never, the images of millions of so-called migrant workers? I say so-called because who isn't a migrant worker? I'm a migrant worker in Boston. But for some reason, we call those who come and labor on our streets and in our homes migrant workers. Who can ever forget the images of these millions trudging back to their villages, often hundreds of kilometers on foot, because there was no public transport, in the blistering summer heat of North India, carrying their children and whatever meager belongings they had on their back. An untold number died along the way out of starvation and because of dehydration. Many commentators noted how these images evoke memories of the harrowing ordeal faced by millions of Indians and Pakistanis, then of course in the pre-partitioned India, during the bloody partition of the country in 1947. But of course, back then, we could blame the colonial masters for their callousness. There's a growing body, of documented evidence on how the lockdown has led to a massive reduction in access to life-saving and essential healthcare. Leave aside all the other services from education, nutrition, and other social welfare services. Since, of course, this policy was primarily intended to control the disease, I'm going to focus on the counterfactual health implications of these policies. Perhaps the most dramatic has been the reduction in safe deliveries. Institutional deliveries, the single most effective intervention to reduce maternal mortality, has fallen by 60% in India in the last 6 months. Mothers are back to delivering their babies at home unsupervised. A student of mine has now documented over 500 suicides, which are directly precipitated by the hunger and desperation due to the containment policies. But beyond India, a UNICEF report published last month has documented that tens of millions of children have had their routine vaccinations disrupted, and includes a large number in India too. And Oxfam published a report a few weeks ago that up to 12,000 people will be dying of hunger every day around the world since the lockdowns began. Most of these deaths, of course, by definition, would occur in the poorest communities. Many Indian economists have predicted that the gains in improving the economy and health of India's people towards attaining the Sustainable Development Goals in the past decade have been wiped out. And if we all agree, and I certainly do, that poverty is the mother of all diseases, then it is very likely that when the final death toll is counted a couple of years from now, it is very probable that more people will have died due to the policies to control the epidemic than because of it. Now, in recent times, historians have documented the final days of the British Raj. This is, of course, when Winston Churchill was a Prime Minister of Britain. Churchill, now we know, engineered notoriously the conditions of one of the biggest genocides in modern history. The death by starvation of millions of Indians through colonial policies which diverted resources to wartime Britain. In a book, Churchill's Secret War, Madhushree Mukherjee writes, "It was not so much racism as much as the imbalance of power inherent in the social Darwinian pyramid that explains why famine could be tolerated in India, while bread rationing was regarded as an intolerable deprivation in wartime Britain." Amartya Sen observes that famine has never occurred in a functioning democracy, a form of government that inverts the traditional power structure by making rulers accountable to those whom they rule. I wonder if that can be really said about India. I will not suggest an equivalence between the colonists' racist ideologies and the events unfolding in India in the past 6 months. After all, even if people are dying of hunger today, there is no mass famine. And of course, India is, at least on paper, a democracy ruled by politicians who were elected by the people, much like the US, I suppose. But where these two historical events really align is in the naked demonstration of how those in power usurp the fundamental rights of the powerless and distort the narrative of the events as they occur. In the past, that power was wielded by the colonists. Today, as the pandemic vividly shows, the role of the colonist has been neatly replaced by native ruling classes, a cabal comprising politicians, the so-called upper caste, a very peculiar social stratifier of India, which I'm sure many of you will be familiar with, the wealthy, and biomedical scientists. I'll return to that point in a moment. Their concerns about this mysterious disease, which began by raiding the homes of the rich and the well-traveled who had returned from Italy, France, Britain, and North America in their global cities of New Delhi and Mumbai, quite unlike all other causes of pestilence, from TB to malaria, which have long sickened the poor but weren't seen in these rich, wealthy colonies, led directly to the world's most stringent lockdown. Of course, this was completely oblivious of the fact that the vast majority of Indians do not travel abroad, and they survive day by day, putting food on the table through the wages they've earned through their hard labor. Even the unlocking process that's been ongoing in the last couple of months is suffused with a class bias. Incredibly, airline travel was permitted before public trains and buses, and urban malls opened before early childhood development centers, which serve food to the poorest children. Even as I speak today, those tens of thousands of early childhood development centers still remain closed, but the malls are up and running. Now, some of you may be surprised by my earlier mention of biomedical scientists as part of the powerful cabal. But it is an inescapable truth in my mind, at least from my context in India, that it was the inappropriate communication of mathematical models by global scientists which used imperfect data. By imperfect, I mean quite inappropriate for the context in which it was being applied, but perhaps more importantly, focused on just one outcome: reducing the pandemic mortality that precipitated the panic reaction in India. Of course, there's no question that there was also panic in India, fueled by the sight of the mighty healthcare systems of Europe and the US being felled by the volumes of people dying. I guess in hindsight, many commentators in India are now remarking that India would have been better off to look east for the strategies to control the pandemic than to the West. But old habits that come from colonial histories are very hard to give up. As Anne alluded, unfortunately, these models omitted the basic principles that no infectious disease spreads in the same way everywhere, for innumerable reasons, from biology to culture. And that context is profoundly important, and that all actions will have results beyond their narrow goals, and these must be anticipated, and they can be anticipated and predicted and mitigated. For example, it does not take a mathematical model to anticipate that if you lock down the economy, all daily wage laborers will go hungry the next day. Indeed, any social scientists would have cautioned against such sledgehammer policies, and they did. They did, because these are people who are familiar with the vulnerabilities in India. But of course, no one was listening to social scientists. This was the moment when biomedicine finally found its place in the sun, and it dug its heels deep. It's perhaps not very surprising that many of my colleagues, biomedical scientists, vociferously called for the government to act swiftly to impose lockdowns. After all of us and the government officials who conjure and implement these policies enjoy salaried jobs, which can seamlessly pivot to online platforms, which we can operate with ease from our spacious homes, in which being locked down can evolve, as it has for me, into a rather congenial opportunity to master culinary skills, practice Zoom yoga, and not have to commute to work. I want to end now by really remarking on another aspect of the deeply unequal power relations embedded in the social hierarchy in India, which is also evident in the biomedical choices the government made to control the pandemic. Instead of relying on the well-tried and tested approach of deploying our 1 million community health workers, India's greatest health assets, and a singular contribution to global health, an asset which has been at the forefront of its success in reducing maternal and infant mortality, aping the West, the country chose to focus on big hospitals and specialist doctors wielding ventilators, untested drugs, plasma therapy, and now the rush for a vaccine. Consider the absurdity for a moment on how distorted this must seem to the poor in light of the fact that 1/3 of India's children still do not receive the full immunization schedule that we have known about for decades. And yet here we are now, months after being tantalized by headlines of billions of dollars allocated to fund dramatic scientific discoveries, implementing strategies we have known about for decades. The humble frontline worker burrowing systematically through the community to identify cases, trace their contacts, help isolate them at home, and restrict movements in areas where clusters emerge. Sadly, though, even though this million-strong workforce is finally steering the country towards controlling the pandemic, they remain the most powerless, and undoubtedly, them being women is also part of that issue, human resource in the health system. In closing, 6 months since the world's most stringent lockdown, and I say the world's most stringent lockdown, not likely, it was actually rated that way by the Oxford University barometer of how strict a lockdown was. 6 months since then, and with 4 hours notice given on over 1 billion unprepared people, with the promise buttressed with all kinds of scientific jargon, complete with curves and experts telling people on television on how this curve would be flattened and reduced by the end of May, we remain mired in the grip of multiple epidemics unfolding with different trajectories across cities and towns in India. The story of India's tryst with the pandemic is, of course, far from over. It is today the world's worst affected country. But when this is finally over, and God knows it will be finally over one day, for all our sake, I hope it will, and an authoritative account of the lessons learned from how different countries dealt with the pandemic is finally written, I hope that a central question we will address is how to ensure that any policy to control the next pandemic represents the needs, aspirations, and expectations of those who are completely powerless. Thank you.
Thank you so much, Vikram. Very, very powerful presentation. And I think you underline how the current moment is also a context in which we have competition between ways of knowing, types of knowledge, and a crisis in expertise, in the sense that these community workers you talk about have been invisible, at least from a Western perspective, as we look at what's going on in India. So it really tells us that to address not only the pandemics of death due to COVID, but also what happens to the poor, we need a much more systemic and global approach to, approaching how it manifests itself across contexts. So thank you so much for these insights. Now we turn to Allan Brandt, who will talk to us about the American context, I believe.
Thanks so much. It's great to be with you. I'm inspired by my colleagues and the other panelists, and I want to thank you in particular, Michelle, for doing this in such a timely way. I think all of us know that today is also a day of remembrance and investigation, especially of racial inequalities and racism in the United States. So I just wanted to say, many of us are taking days off doing different things, but I felt that the teaching and learning potential of this particular session was really in the spirit of the strike itself. And I just wanted to note that. And I think that's already become clear in the first two presentations. And I look forward to hearing my other colleagues who will follow me. Historians have been invited to make sense about what's going on. And it's been unusual in that way because we're not often consulted very often, but I found that in March and April into May, my phone was ringing and people were saying, what can you tell us? You know about past epidemics. Can you tell us anything that will help us understand what's going on now? People looked for analogs, and there's been a lot of discussion of the plague, which recurred throughout centuries from the 14th century. Even more attention, as everybody knows, to the influenza pandemic, which followed World War I. We've seen a lot of slides. I want to use these in a way as a way of thinking about this moment. It's obviously a photograph from 1918 and the massive illness and death that occurred then. The invention of terms that were using quite easily now of social distancing, preventive equipment and masking. During this epidemic, intensive debates about whether to wear masks or not, whether to close down businesses, bars, churches, schools, that resemble in some ways our current moment. A lot of talk about flattening the curve. This has become an iconographic image in this epidemic from 1919. Interestingly enough, in that epidemic, we collected data on racial difference, and that's always been a key element of introducing aspects of why people have differential morbidity and mortality. During the 1918 to 1920 epidemic, the racial differences in deaths and illness were typically ascribed to the biological character of people who were Black. And this is also one of the legacies. One of the things that historians try to do, and people have asked me a lot about, is how do we compare the size of epidemics? How big will this epidemic be looking ahead? How does it compare to the Black Death or to HIV or a variety of influenza epidemics of the 20th century? And I have to say, personally, I found this enormously frustrating and relatively misguided. The idea that somehow deaths is a marker that moves in a decontextualized way through history, I think is not the way historians really can and should be thinking this through. I was thinking as Anne presented that she was looking at forecasting practitioners, future practitioners, foresight practitioners. The way I think about my work in some ways is that I am a hindsight practitioner. And historians have been struggling now for 40 or 50 years to think about how to utilize disease to understand a variety of things about the past and the present. And so we've centered attention on the nature and meaning of epidemics. Many of us have heard during this epidemic that disease lays bare social relationships, institutions, politics. And my colleague and friend here at Harvard, Charles Rosenberg, wrote a very important book in the early 1960s, a book that was prescient in terms of thinking about, as historians, what we actually can get from investigating disease. And part of this relates directly to what Vikram just spoke about, that when the history of COVID is told, we will see that, in a sense, the term Rosenberg used, that we're living in a natural experiment. We see the differences between cultures, nations, communities. In the United States, we've had an experiment, if you will, of 50 different states trying to contend with the epidemic, often with radically different perceptions and politics, with radically different resources and cultures. And so Rosenberg said disease is like a sampling device, and historians can use it to understand the past in some meticulous and subtle ways that we might not otherwise see. And the other one that's come up a lot lately is disease is like a stress test. And here we think of the Great Recession, where we test banks with various stressors and economic changes. But I do think one way that we have seen COVID play out is that any weakness, any social inequality, any systemic or structural injustice is illuminated in a moment of epidemic. And I think this is what historians can really potentially bring to our understanding. I'm always cautious about using metaphors, but as I was thinking about today's presentation, it occurred to me that for the most part, we're in the dark and the lights are out and we can't see many things, and they're made invisible by deliberate social and cultural and political engagement. And then in the moment of a pandemic crisis, the light flashes on. And it's always hard to adjust to the light, but we can see things that have been purposefully and intentionally often made invisible, and they become visible to us. And we're in a moment of visibility about the predicates and the social roots of the COVID epidemic. So how do we understand the context? Historians are deeply engaged in understanding what could we have done differently? What were the decisions that were made? It's about returning a degree of potential agency to the questions that arise in a pandemic like the one we're facing. A lot of what I'm saying depends on the work of Arthur Kleinman and the idea of explanatory models, which were not just about how patients and doctors explained what was happening to them, but in a social and political context. How do we understand what's happened to us? And so I think that there are a number of characteristics of pandemics, and we've heard some of them already discussed. But I guess what I would say is, echoing what Vikram said, is that these characteristics play out in profoundly different ways, in profoundly different places, all going on at the same time. So it's hard in some instances to generalize, but this emphasizes the point I'm trying to make of the importance of understanding our current context, but that no epidemic and no epidemic crisis can really be understood without understanding the past, because the current epidemic exposes the character of our history. So one of the essential questions, and we've seen this play out, is what are the differences and vulnerabilities among people in the United States, across the globe? One of the ways we've seen this play out is by saying, well, COVID is especially dangerous for people with pre-existing conditions. And then we see those pre-existing conditions laid out. Typically, they're heart disease, diabetes, and obesity. And that, I think, is a powerful trope. All of those illnesses are highly associated with aspects of racial disparities. So what is the differential and vulnerability? That is used, and we see it get used, especially in conservative media, to explain why there are these differentials, and in some ways make excuses for the real character of vulnerabilities, which is poverty and especially systemic racism. So looking closely at context reveals not what's the microorganism, but what are the pre-existing conditions, if you will. And in this instance, the pre-existing condition is racism to a large degree. And this shifts notions of responsibility for disease. This is a problem I've been working on in my work on stigmatization. But as soon as we cross a barrier of disease being the result of behaviors, it's very easy then to stigmatize the condition. And what we find over and over again in the history of disease is that morbidity and mortality track fundamental social inequities. So there are ways that social scientists have come to think about this. In our Department of Global Health and Social Medicine, and a lot of Paul's work has focused on what we think of as biosocial, the profound integration of the conditions of the body with the conditions of society, and especially disparities in income and around issues of race and ethnicity, the interconnections between biology and culture. Obviously, and I think this has been a profound issue in the COVID epidemic, the biopolitical and the political range of constructing the meaning and character and responses of disease. And in many ways, this reflects on highly influential, profoundly important work about disease and its response as forms of governmentality and discipline following Michel Foucault. So I just wanted to say a couple words about preparedness in pandemics and how and when COVID will end. I found Anne's presentation just fascinating. And one thing we might ask about preparedness, as she pointed out, is we had scenarios of global respiratorily transmitted pandemics. We had scenarios of how we would respond. We have historical examples of how we've responded to SARS and Ebola. And so for those of us in global health, and I think even more widely, there was nothing that surprising. People were saying, we can anticipate a pandemic like COVID. So the question I want to ask is, what does preparedness mean? What would it mean to be prepared for COVID-19? And it's not having necessarily vaccines and medications warehoused. It's about addressing fundamental questions of social injustice and inequality. That's how you prepare for pandemics. I think COVID will end, and I'm as eager as anyone to see vaccines and effective treatment. But I would say this: as long as we focus on this biomedical approach of a single disease with an agent that we either try to treat or destroy or conduct immunity for, I think it's a losing game. And so I think that biomedicine, in its focus on individual diseases and how to potentially alleviate them, misses in a fundamental way the broader social determinants of disease. And if we want to be prepared for the next epidemic, then we have to address systemic racism and structural inequalities. And what I fear, as I look forward, having looked backward, is that a pandemic can enhance inequalities. It can enhance health inequalities. And it's very hard to be confident that this is a transformative moment unless we can keep the light on and really address these fundamental questions. This is in today's New York Times. It's about an African-American gay painter who's been quarantined. And he grew up really during the AIDS pandemic. And I think it's worth noting, we asked the question, when will epidemics end? The AIDS epidemic has never ended. The tuberculosis epidemic has never ended. And they haven't because of the difficulties of implementation, of getting drugs to people who need them. And he was reflecting on the relationship of his experience during the AIDS epidemic and art. And this was the quote. I can't see it because I'm in the way here, but here we go. As with AIDS, the struggle for racial justice in this country depends on visibility. Once something becomes visible, Mr. Bradford says, it becomes everyone's problem. So if you choose to turn away from this moment, I feel that's your choice. But one thing you cannot say is you didn't know. Thank you very much.
Thank you so much, Allan. What a powerful conclusion. As I introduced the panel, I should have mentioned that as the scholars strike was announced over the last few days, I consulted the panelists about whether we wanted to cancel our panel or go forward as a way to honor and contribute to the education that has surrounded the protest around racial injustice. And we thought that given our topic and given our respective expertise, we could really think of this as a teaching moment where we're contributing to the cause in solidarity. So we agreed to move forward, but also to express our solidarity with the movement at the very beginning, which I forgot to say. So my apologies, and thank you, Allan, for reminding me. So now we turn to Paul Farmer. Paul, the screen is yours. I think you need to unmute, Paul. Okay, you
All
go.
right, sorry about that. Thank you so much, Michelle, and thank you for remembering, and I know it wasn't hardly, our solidarity with scholars in support of the Black Lives Matters movement. And like my other colleagues, I'll be addressing this rather directly. Some of the lessons from Ebola in West Africa, I should have said West Africa, I will not underline here, but there are many of them are about the long history of the relationship between this part of West Africa, which includes, in considering the Ebola epidemic, Guinea, Liberia, and Sierra Leone, which was once called the Upper Guinea Coast. The relationship between this part of that continent and Europe and the Americas, of course, was established in the 15th century and rapidly gave way to the extractive economy that would change forms over the century, but would initially be based for quite some time, maybe centuries, on slaves and gold. And one of the surprising things about being drawn into the Ebola epidemic held to begin in 2013 were the ways in which expectations, both for disease containment, but particularly for clinical care to the afflicted, the way in which expectations were lowered and lowered and lowered. There are a lot of, as we struggle, and this goes back to Anne's presentation, as we struggle to gain mastery of the narratives, because they're competing, as has been pointed out by Anne, I would just like to kick this off by saying, I'm not at all sure that the real lessons from this Ebola experience have been internalized, but I do want to say at the outset that I think there's more of a chance now for us to capture these lessons than before. So I'm not going to go deep into the history of the forced migration of 12 million people across the Atlantic, which is probably the largest forced migration in human history, although Vikram's story gives you pause, and we'll happily turn to that in the questions. I want to instead, can you advance that? Oh, maybe it's over here, sorry. I want to instead, in the spirit of this, express some of the uncertainty that occurs in the middle of a pandemic, since I was also in Sierra Leone, really for the first time at the outset of this pandemic, and same with Liberia, and have been working there since. First, just a word about Ebola, because the origin stories, as social historians have told us, the origin stories are always important and revelatory. They shine that, they turn on that light as well that Allan mentioned. This type of virus was first identified in Germany, of all places, in Marburg, and bears the name Marburg virus. And the way it happened, and very briefly, is that a shipment of primates, not for basic science research, but actually for polio vaccine production, was sent from Uganda, captured and sent from Uganda via London to Marburg, Hamburg, and Belgrade in then Yugoslavia. And there was an exposure, and this virus, which had been unidentified, of course, spread rapidly. Now, because I want to talk about the low expectations, I'm going to mention at the outset that the case fatality rate, which, as Allan brings up, is a constant reminder of how social disparities get in the body. The case fatality rate of an unknown virus in the middle of fairly prosperous European cities with the staff, stuff, space, and systems to make a difference, case fatality rate was about 20%. In other words, the great majority of people who were infected, and they were lab workers, clinicians, and close family members, and also there was documentation of sexually transmitted Marburg, most people survived. The same virus, once identified, was seen to be, and it was thought to be at the beginning, a virus that was much more common in the heavily forested regions of Africa. A zoonosis of some type, the host that would not be sickened by the disease are thought to be bats, but it's not clear. In those outbreaks, when they were, on the rare instances they were documented, mortality rate routinely exceeded 80%. So think of that along the lines of what Allan said. How are such disparities explained? What work does that do? Right? And then came another explosive outbreak, this time in a village in northern, what was then Zaire. And I have a picture of some Flemish nuns here. And I want to tread very carefully. These are things that I've written about over the years, but this epidemic was uncovered because it hit a mission hospital in a village called Nambuku, not far from the Ebola River in Zaire. Now, I had written about that, but I didn't really look into the details of what had happened in enough detail. But basically, one of the stories was that the nuns, that they were Flemish nuns, missionaries. This hospital, by the way, had all of 0 doctors working in it. So again, would a 100-bed hospital without a physician be called a hospital? Well, not in Flamand, not in Belgium, where they came from, but definitely this was not unusual. And in some cases, it's still not usual. So in the course of providing prenatal care, which generally does not involve injections of vitamins, they reuse needles, again, something that wouldn't have been done in Belgium. And that's what was the epicenter of the first cases around the hospital, and then in-person transmission from person to person within the hospital. Every outbreak that is of either of these that has been studied since has been the same story. So imagine, given that we had at least some knowledge over the decades of these pathogens, why was there so much confusion in the middle of what would prove to be the largest outbreak ever documented? And part of that, I'm saying, and going with Anne, is the uncertainty that does seize people when they are in crisis or perceive that they're in crisis. And let me just go forward with some illustrations. First of all, as I mentioned, our purpose there, as Partners in Health, which is a charitable organization affiliated with our department and the university for a long time, our purpose was to address clinical nihilism. And my colleagues have written about this. This is the idea that there's nothing that can be done. Just a famous example, I'm sure, is working its way into Allan's new book, as it has into his previous ones, is AIDS. Once effective therapy was developed, it was just too expensive, not cost effective, not sustainable, not feasible to treat AIDS patients in Africa. I mean, this is not contested, meaning the conclusion was contested, that these claims were made by some of the same people Vikram is talking about, were made again and again. And they weren't usually from biomedicine. They were usually from public health. So again, going back to the Flemish nuns, who I do not wish to disparage, this is called socialization for scarcity on behalf of other people. And they happen to be Black and brown people, right? And this has its roots, this control over care paradigm, which has its roots in colonial medicine. And I'll go to that if there's time, or in question and answers. So what was, why was the spread so rapid into urban areas, becoming, quickly becoming, within a few months in any case, the largest epidemic of Ebola ever documented? Well, of course, the reasons were contested. And you remember this from 2014 and on, it always goes on. First of all, just not like the Wuhan wet market entirely, but what people eat was again invoked again and again, bushmeat. Now, I will point out that it was clear from the first outbreaks of both Marburg and Ebola that it wasn't through eating bushmeat, but rather through person-to-person spread in the acts of caregiving. And Arthur, I think, will talk to us about that. Caregiving, of course, the majority occurs inside families and in places where there aren't professionals among traditional healers. and the last act of caregiving is burying the dead. That was the story in 1967 and 1976 and in all documented outbreaks. But also you'll see claims about the exotic rituals, behaviors, comportments of the natives. And again, there's a rich history of this in colonial medicine if you can stomach it. Less commonly addressed, as has been pointed out by Allan, are the structural determinants of risk for both outbreaks of infectious pathogens, whether spread through respiratory means or person to person, and the risk of outbreaks of violence in the face of extractive regimes. There's really very little evidence that the introduction of extractive regimes into this part of West Africa did not cause violence again and again, century after centuries. Massive wars, sieges, it just went on, including through the early colonial years. And then all-out civil war broke out in 1989 and lasted for 15 years in Liberia and Sierra Leone combined. This is the same war, not two different wars. And this, of course, is a diamond pit not too far from where we work. And a reminder that these structural determinants are going to be important, if not in the short term in managing clinical nihilism, right? The task there is to take care of patients. But understanding how it spread was also revealed very quickly as Newsweek ran photos of chimpanzees on the cover to talk about the hidden risk of bushmeats. The bushmeat, the people that we talked to and took care of told very different stories. For example, these are a young couple and a best friend. And the young couple, the young woman there, her grandfather was a traditional healer in rural regions to the north of Freetown, the capital. Her father went to take care of him when he was sick. When he came back to Freetown, he fell ill. His daughter took care of him. Her boyfriend/husband took care of him and helped to bury him. And her best friend also cared for him. This is the story among the health professionals, but also in the lay population, a caregiver's disease. Now, I want to just close in thinking forward about some of the lessons we learned. And I'm going to acknowledge right here that I am still struggling with a lot of these lessons. One thing that is easier now, thanks to what has been underlined by Anne and Vikram and Allan, is that the light that gets illuminated by other experiences, whether they be in the past or in the future when compared to 2014, are illuminating. One thing that I know I saw was a control over care paradigm, right? Disease control, including the sledgehammer mechanisms that Vikram mentioned, was always more important than the clinical care of the afflicted, which remained clinically paltry to the very end of the epidemic. The death rate, the case fatality rates of Ebola inside West Africa were not lowered at all in the course of those 3 years. Meanwhile, every white American who was airlifted out survived. So did most people airlifted to Europe. And I guess unless we want to go back to racial essentialism to explain this, we're going to have to understand how context makes a difference in both risk of getting a disease like this, a risk of dying. And that requires understanding staff, stuff, space, and systems as mundane or materialist as it can seem. Right? The ways, the lessons that Vikram mentioned, and the army of contact tracers and community health workers, really the same thing, right? These are people who provide a living link between institutions that should be serving the population, meaning clinics and hospitals, and the homes in which people live. These are just some colleagues of mine. We took the same lessons about flattening the curve, contact tracing, the importance of social distancing, wearing masks, and like many others, tried to apply them in Boston. In fact, if you look at the U.S. response, you'll see this tardy. This is actually Massachusetts was first out of the block. Probably this is one of our Liberian graduate students here at Harvard working as a contact tracer during the COVID transmission, using his own experience in Liberia, of course, to make a contribution in Massachusetts. So the sense of, confusion, not knowing what to consider, like lockdowns, these all occurred during the Ebola outbreak. Well, what did one say about them? Were they effective? Were they ineffective? They had the same impact, if not on the massive scale that Vikram describes. You know, rural agrarian people who are told to shelter in place and can't garden or tend their gardens or collect food or water from without a walled off village. It's a dramatic situation to live through. And, you know, you got the sense that this was not the right way to proceed. But in Massachusetts, and I'll close here, Michelle, in Massachusetts, I think it would have been very hard to see clinical nihilism or nihilism. And it's been, you know, historians can give other examples, but the reason Tuskegee is so infamous is that it denied treatment to African-American men after that treatment had been developed, right? I mean, that's, Allan has written a great deal about this, but if you take that globally, without restoring the history of slavery all the way to the current diamond trade, if you take that example and say, well, clinical nihilism is often manifest across national and continental borders as well. But in Massachusetts, what I saw in any case, or what I thought I was seeing, was containment nihilism, right? There's nothing we can do. The epidemic's too out of control to employ contact tracers. You know, the public health system will work well enough. All of this was encountered on a regular basis. And I that's one reason I have a lot of respect for the governor of Massachusetts, who actively attacked containment nihilism at a time where I don't think we were as vulnerable as the rural poor in Sierra Leone and Liberia to clinical nihilism. And that's what killed them, the clinical nihilism. But what we saw here was different, and I'm sure we're going to be able to find examples of clinical nihilism as well, but really the containment nihilism is what we're stuck with now. So going forward, again, I echo all the speakers so far. We need massive investments in staff space and systems in the United States as elsewhere. And it has to make sense, right? We have 350 local health departments in Massachusetts alone. And you can imagine trying to coordinate an intervention. But the amount of money that's invested in public health is so small in the United States, such a tiny fraction of what gets paid out. And we're feeling that and are going to feel it for a long time. And as Allan said, the development of vaccine or effective therapeutics is not going to change this. But I do want to say, in echoing my colleagues, that this is a time, possibly, at least in my lifetime, I have never heard so much discussion of health insurance, unemployment insurance, racial justice, stopping police brutality, addressing our prison crisis, the conditions of workers in meatpacking plants, the conditions of people shoved onto reservations in a previous century. Never in my life have I heard so much everyday discussion of this. And so, again, back to Anne's presentation, do we assert our agency and shape the future? And of course, that is what so many of us hope for. Thank you.
Thank you so much, Paul. And thank you also for ending on the note of hope and noting that, you know, this is also a moment where there are opportunities for social change that and the work that the presentation you gave about the distinctive, the situation in Massachusetts, the infrastructure, et cetera, are really important in feeding our understanding of where should we put our action and where is the potential for change. So we conclude with Arthur Kleinman. Go ahead, Art.
Hey, thank you, Michelle. Thank you for inviting me, and thanks to my co-panelists, all of whom have done a splendid job, from Anne through Allan, Vikram, Paul, and I'm delighted to tell you that I am a colleague of Paul and Allan and Vikram, and I wish I was a colleague of Anne. Well, I'm going to draw my remarks from a book that I did last September, The Soul of Care, and 4 op-eds that I wrote during the early part of the COVID epidemic, as well as from a project that I have going on in China right now called Social Technology for Elder Care and Dementia. And what I want to do, however, is to periodically insert examples from the Chinese experience and other experiences around the world, but to focus on the United States, because that's been the centerpiece of my experience, as it has been for all of you through COVID. So COVID is a mirror that's held up to us. And so this is my image as against Allan's image. Had I heard it earlier, I would have used the light bulb image. But this mirror has plenty that is not good to show us. One of it is that we have basically a broken and absent long-term care system for healthcare in the United States. And that system is one of the major reasons, along with the racial injustice and social disparities, that 70% of deaths have occurred amongst the elderly, and particularly amongst the elderly who have borne the brunt of those racial and social inequalities. But we should also recognize that there's a kind of diversity of problems that mirror recognizes. So for us, it's no organized national response, every state on its own. It's the politics getting mixed up with the implementable public health, so that we have debates about masking and angry responses of a libertarian kind to the infringement on freedoms because people are asked to follow public health measures. We also are living through an age that can only be described as an anti-caring age. The leader of our country is I'd say, the paragon of anti-care. Now I can compare all of this to China. So China is a non-democratic system. It's a organized communist dictatorship. And the same kind of problems that came to us out of our political and social consequences that have been organization have been very well presented by my preceding lectures. We can talk about for China. So whereas we've had this diversity of response, the Chinese, including their failures and successes, have occurred out of a uniformity of response. And the fact that in the Chinese system, low-level politicians, bureaucrats, cadres, political cadres, are frightened to pass bad news upward. And the result of this was delay, significant delay, in the, not only in the expression that there was an epidemic, but in important elements of that epidemic, such as the fact that the Chinese recognized that there was person-to-person transmission early on. But once this information got to the center acted with what is characteristic, a brutal but systematic and effective total response. And you had a lockdown in China that could never have been effected in the United States. And this lockdown has actually led to the fact that the Chinese outcome has been pretty good out of this. Late start, responsible for that epidemic becoming a pandemic in many ways, because had the Chinese had that information at the center early, had they closed down travel out of Wuhan and out of the entire province early on, there would have been probably no pandemic. Or there would have been a pandemic similar to SARS, which for us in the West was a minimum pandemic, as opposed to the maximum problem that this pandemic has become. But there also are positive dimensions in the United States and in Chinese society of our experience. And I'd say the most positive part Paul mentioned, which is that before the pandemic, 50 million Americans were family carers. Now, all Americans are family or self-carers. We've all had the recognition of what a pandemic can do. We're all focused on health issues. We recognize health disparities and how powerful they are. We see a broken healthcare system. We see the importance of having people insured so that the 33 million Americans right now who have no insurance are covered. And we all experience acts of care, of caregiving, taking care of ourselves and taking care of others, making care a central idea that we can build on. And that's what I want to emphasize in this talk. In 1939, the Nobel Prize for Peace was given to Jane Addams, the first Nobel Prize for Peace given to a woman. Jane Addams was a leader of the American progressive movement, a social reformer, a feminist, the founder of Hull House Settlement in Chicago, an anti-racist, and a woman who believed that the object of the state, as she put it, is to nurture and protect life of its people. She argued and lobbied that the vision of governance was governance through care. And she said that came out of the experience explicitly of women and not men. And hence it was important for governance to reconceive of itself in a feminine perspective, feminist perspective. Since that time, feminist ethicists have argued the same point, but haven't had the occasion to demonstrate it so clearly as we have and so visibly right now. Now, in future, we may go back to the status quo anti-COVID, but there are historical examples of epidemics that led to substantial change in public health and in social policy. The 1830s cholera epidemic in the UK basically led to the development of the UK's public health system and its concern for social welfare. Out of that epidemic, and also out of the terrible effects of the Industrial Revolution on workers, came the social sciences. The social sciences were initiated, not as some abstract set of ideas or concerns, but to reform society and to address social problems. That's in a book, there's a source for that, if you like, that reviews the attempt over the years to return the social sciences to that initiating concern. That's in the book by Wilkinson and Kleinman called A Passion for Society. So I perceive the possibility in the United States that things may be different. We may have a change at the level of leadership, institutions, policies, and regulations. Of course, we may not. But I'm going to look at the positive side of this and saying, what does that change have to be about? One of the big parts of that change, and the one I want to sort of emphasize right now, because it leads to so many things, is the importance of the transition we're going toward aging societies. In 2040, Japan will be the first society in the world in which 40% of the population will be over 60 years of age. At that time in 2040, 30% of the Chinese population will be over 60 years of age. In the United States, between 25 and 30% of our population will be over 60 years of age. This is the population of diabetes, heart disease, cancers. This is the population that needs a long-term care system. What COVID in a way has shown us is that COVID has become the pneumonia of the 1920s and 30s that kills the elderly who have these chronic conditions. Now, there are some societies, by the way, that have done some remarkably negative things in this regard. Sweden decided, of course, that it was going to go the direction of herd immunity, and actually has tolerated euthanasia in its nursing homes, basically knocking off the older population. It's had successes in other domains. But the United States and China are very concerned with this aging population. And I believe that this will be one of the central connections we have in the future as we try to back off in US-China relations from being adversaries to being strategic competitors, what we were in the Obama era. And it's in the area of epidemics, pandemic disease, long-term care, aging, that I believe policies can be thought about across the world and between China and the United States that may change things. And so here, I want to look explicitly at policies in the United States that we need right now that speak to the epidemic and that suggest that preparedness, as has already been expressed by others, is not just preparedness for the epidemic in the sense of epidemic-specific, pandemic-specific public health measures, but in changing social circumstances. So the policies that are highlighted by COVID for us in the United States that we need are high quality, affordable childcare and elder care. Very few Americans have long-term care insurance, okay? I took care of my wife and her Alzheimer's disease for 10 years. In the last 9 months of her disease, she had to go into a nursing home. The cost of that was $200,000 for 9 months. All right? Very few Americans can handle elder care. We need an elder care system. Compensation for family carers. 50 million Americans before COVID were family carers. In COVID, the number is in the hundreds of millions, okay? Uncompensated care. If we look at just the elderly in our society, 70% of the elderly in our society either live by themselves or live in families. If there was a 10% change in that, it would be a surge that would overwhelm all institutions in the United States. Family care must be compensated. A right to request part-time work and flexible work, really crucial. That is seen right now and is happening right at this moment. Investment in early education and in education of all kinds. Our attention fixed on education. And from the standpoint of COVID, with particular concern for teaching civics, basic civics, and the idea of communal responsibility, not just individual rights. Teaching tolerance and cultivating caring qualities, seeing care as an essential quality. Comprehensive job protection, crucial. Increased salaries, training, and status for home health aides and for nursing assistants in nursing homes. The only caregivers we have in nursing homes are women of color who have back-breaking jobs that are poorly paid, terribly paid, have no status, and are undesirable to all, including them, if they have an alternative. Support for community services for the mentally ill and the elderly. I don't have time to talk about the mentally ill, but if we look at the impact of COVID on the mentally ill, it's enormous, et cetera. And it's a mirror again that reflects on the fact that we have no mental health care system. Our mentally ill are on the streets or in prisons. Affirmation of the right to care and the building of a national healthcare system, a real national healthcare system with national insurance. The syndemic that we're in points to the reform of the criminal justice system, including the police, the courts, the jails, and prisons, making care as central as punishment is to those systems. I don't need to talk to this. This is really about what the scholars' strike is about and about what Black Lives Matter is about. It's a central part of the syndemic. Housing reform, and also making college possible for all adults. Equal pay for men and women. Protection of women's rights, to choice. Development of policies for social care of the poor, the disabled, the racially discriminated against. Gun control. National service for 18-year-olds, so that besides having a military, we also have a domestic corps for helping to take care of our society, of our environment, of the people in need. Rebuilding the global financial system to address the harms of neoliberalism and the immense inequalities fostered between rich and poor. That is right there in this epidemic. Rebuilding the UN and global relations. When we look back at this, we're going to see it's not so much that WHO failed, it did fail with catastrophic results, but WHO couldn't but fail because of the way that the UN system is set up and the responses of countries like ours, which contributed to that failure. And so that's my endpoint. I would say that I'm optimistic about the United States. I'm also optimistic about American relationships with China. I haven't had time enough to talk about China, but because we bash China all the time, we don't recognize the enormous contribution that China has made to health in the world. It has unprecedentedly reduced poverty. It has improved health in such a way that it is an epistemological, not a statistical difference. The infant mortality rate in Beijing in 1949 was 500 deaths per 1,000 population. Today, it's less than New York City and less than any American city. It's astonishing. China's poured money into its healthcare system at a time that we've restricted. We've been continuously concerned with the fact we're spending too much. China is in many ways an example of the fact that we can misrepresent important health changes that we can learn from in the same way that the Chinese can learn from us in important sense. And the last point I want to make is that I have learned so much from the people who talked before that I think what I would hope would be the Weatherhead Center would not just let this drop and become just a recorded session for others to listen to, but that out of this will come the kinds of questions and further developments that could be a kind of program that's important in the Weatherhead International Center, seeing the crucial role of health internationally. Thank you.
Great suggestion, Arthur. And I very much like the way in which your talk emphasized our questions of cultural membership and caring are really at the center of all that is now framed as biomedical questions. And we have 15 minutes left. So I thought that instead of opening it up so that you can ask questions from each other, I would invite our audience, there's still 100 people out there listening to us, to post questions on the Q&A function on the screen, and I will read these questions and ask you to respond. It seems that the audience may be a little bit shy to the extent that there's no question right there for the moment. So maybe just to get us started as we're waiting, I would ask all of you to reflect maybe on this question of caring that Arthur, concluded, well, topic of his talk as a whole, in the context where the US has been spending tons of money over the last few months in unemployment compensation, et cetera, but not in rebuilding the infrastructures that are broken. And the monies that have been spent go to individual and not to collective projects. So what are your thoughts on how we deal with the fact that this country is so allergic to collective projects at the time when the expenses should be very much targeting, the infrastructure or supporting the kind of community medicine that Vikram talked about? How do we go beyond the really individualist impulse that is behind so much of our, of American culture?
Michelle, I'd like to ask Allan Brandt to respond to that. Allan, can we have a new progressive movement in the United States?
Well, I certainly hope we can. And, but, I think like a lot of us, I'm anxious about the future. I see in a highly polarized way, many of the, opportunities in this moment. And, as I sort of metaphorized about it, the light switch has gone on. But I have a lot of worries also. And, when you're addressing deep systemic and structural problems that are cultural, as Michelle points out, a very strong tendency towards individualism and individual responsibility, how do you recapture a sense of the social and the community? And I think this is the contest in our culture right now. I do have concerns because I don't think you can just say, well, now I'm anti-racist and, we've solved that problem. And one of the things I've been observing in the pandemic is we all have a lot of hope in a vaccine. There has to be a process by which we know a vaccine works. It's been very difficult to get people of color into vaccine trials, which is crucial if we are to provide people with a safe and effective vaccine, especially those who have been at greatest risk in minority communities. And I've reflected a bit on my early work on the Tuskegee syphilis study. And I sometimes find myself asking, why are we still talking about that? It happened starting in the 1930s, it ended in the 1970s. And it's terrible injustice, as Paul pointed out. It reflected a clinical nihilism. Why treat these people? Let's find out what happens. But the reason why it remains so indelibly linked in our culture is we never address the fundamental questions. And I think it's hard to make those shifts, but there are real potentials now. And while we see what's going on, while we see the failures of these approaches, why, of course, a pandemic's going to be worse in a country that doesn't have a unified healthcare system that has universal access. There are reasons for accounting why we did so poorly. And if we understood those best, that's a form of preparedness. But those really involve a kind of rigor and a kind of public awareness and, quite frankly, public activism. I've never seen anything change in health where there weren't people in the streets. And I have to say, just reflecting on HIV, and I don't want to talk for too long, I'm surprised in some ways that we have marriage equality guaranteed by our Supreme Court. I never would have predicted that in 1982 or 1992. And when people say, well, what happened to HIV? It's because of treatment. No, it's because there were people in the streets and their cause was just and they communicated it brilliantly. So there are models for positive social change.
Great, thank you. Now we have 9 questions, so I will arbitrarily choose 2 that are very interconnected and open it to anyone who wants to answer. From Peter Hansen, the question is, based on your perspective, what advice do you have for speaking to people who are very skeptical of the recommended public health measures, or speaking to those who are very fearful of going out in public or going to class in person? So that's one question. And a related question, I guess, is by Lucas Shu. What can academics, specifically students, do to forward some of the recommendations that you have laid forward? So what do you say to your student about, we face this moment, what can they do on a daily basis?
I can give an example on the students, just a real quick example. And there are many examples from Harvard, but a Yale student created a NGO, I think it's called Invisible Hands, relatively early in the pandemic. He created in New York City where he lived. He asked for volunteers who would help the elderly in terms of helping deliver food, helping them with medical appointments, and et cetera. Within 4 days, he had 1,200 volunteers. At the end of a month, he had 12,000 volunteers. That's the sign of American volunteerism. There's an enormous amount of American volunteerism. This student should go to COVID-19 mutual aid. And we'll see many kinds of examples. There are all sorts of ways that one can volunteer and be helpful. And Harvard students are doing it right now.
Great. Any other ideas that you would like to propose?
Can I just add something to the first question? You know, what I tried to describe and what I've seen again and again is something that I'm reluctant to call out. You know, you can use fancy terms like social, socialization of scarcity on behalf of other people who happen to be brown and black. But what troubles me is a strain of public health that is not biomedicine. Biomedicine has to be a parent category of some sort, right? It's a public health logic that favors strict disease control over care, caregiving, compassion, and it's evident to people. It was evident in the AIDS epidemic when people said, "Oh, you know, you don't need to get out in the streets. The FDA is working as fast as it can." In Africa, around Ebola, again and again, people are frightened by this logic whenever it's divorced from care and caregiving, right? And so one of the things I said to the contact tracers in Massachusetts in the times that they asked me to address them, or those who are training them, is the thing that you need to underline if you get through on the telephone to a person is that you're there to serve them, to help them. You know, people aren't signing up for quarantine, isolation. These have to be made not just palatable, but part of the caregiving package. And when they take on this, enormous dimension, yeah, that's why people are frightened. Students are frightened as they come back to school, maybe not frightened enough, I don't know, but I'm just saying, when we don't link prevention and control to caregiving, we get these kind of social responses again and again. Tuskegee, early AIDS, Ebola in West Africa in the summer of 2014. I've never not seen it happen.
So concretely, what do we need to do?
We need to remember that people need staff, stuff, space, and systems to, receive good quality care when they're sick or injured or frail and elderly, as Arthur said. And we don't have that. And that's something student activists can work on as well. Many are.
But I'd like to add to that. I think probably we also need one more S, Paul, and I'm sure you'd agree with me, and that's solidarity. You know, I just booked my ticket to come home to Boston earlier today, and my travel agent said, you know, the flights have just begun, and he said, well, you're going from the world's worst affected country to the world's second most worst affected country, so you probably don't have to do much testing, because either way you're going to get infected in one place or the other. And then it struck me when I looked at the latest league table of the 3 worst affected countries in the world. That's India, the US, and Brazil. And I wondered to myself, you know, and I'm sure many people have observed this, it's not just that all 3 are ruled by men, but actually all 3 are also perhaps the most polarized societies that I can think of. And at some stage, I'm sure political economists would be interested to look at whether there was any relationship between solidarity within the country and the ability of the country to get past the pandemic. Because certainly on a very naive way, I have to say the 3 worst affected countries surely are absolute exemplars of divided countries in terms of political polarization, which I think makes it much harder for people to stand together at a time of crisis, which is really what we are all facing in these 3 countries.
Exactly. Anne, you also wanted to make a comment?
Yeah, well, I would agree with the need for activism and protest and not relying on an overly optimistic sense that just because we're in a moment of crisis and transformation that things are going to transform on their own. And I think in light of that, we have to think about how do we do, you know, how do we do short-term and long-term responses and narratives of change together. I mean, as I was listening to the other panelists, and you know, this idea that in a pandemic time, what happens is you shine the light, you know, or the mirror, you know, on long-term social injustices, structural problems, inequalities, exclusion. But you do it at this time when you have this urgent need to like stop people from dying. And so what's you're revealing longer term problems when you have to mobilize for a short term response. And that's a tension. You know, that's a tension in how do you pull those 2 things together? Like how do you okay, so we stop people from dying, we alleviate the public health crisis, and then things go back to normal. And the spotlight disappears. And this moment for transformation just can slip away so easily. So I think that's part of the challenge. How do you keep it focused on the underlying, you know, as Allan said, you know, what would it take to be prepared? Well, you know, let's change these structural problems of social injustice. But, you know, in Lakoff's book, it's kind of revelatory. He says that, you know, part of the problem with these regimes of preparedness that focus on disaster preparation, which is important, directly compete with resources for public health infrastructure. Mm-hmm. And so to lead to the you know, spiraling of the problems that we have when we have a catastrophe, when we have a disaster. Mm-hmm. So, you know, in activism, you know, the longer term and the, you know, extreme preparation for extreme events, you know, it has to be coupled with, you know, both like short-term responses and long-term views of structural change. And I think that's really hard. I think that's really difficult, but it may take a shift in how we do foresight. So, like one last point with like Vikram says, he said that, you know, it didn't take a mathematical model to understand that if you draconian measures were going to hurt the poor. Well, if that wasn't so hard to imagine, why didn't somebody imagine that, and why wasn't it acted upon? Because that's not the way that planners and people in government of power do foresight. Mm-hmm. And so if there's a way in which we shift the way that we do foresight to, again, to combine this, the longer term and the short term, and then connect that with, you know, activism and insider outsider strategies, I think is one way that we can take this transformative potential, but not yet actuality of this moment, mm-hmm. to move us forward.
Yeah. Several of the comments mentioned the mobile health workers of India as a very interesting model, but strangely enough, as they could have been mobilized, they were not. So that is quite a puzzle. I mean, ideally, you know, this would have happened. So maybe to conclude, I'll ask Vikram to comment on that, and then we'll.
Well, I will, but I think Paul can also comment, because I think Paul's observation about how PIH was brought to Massachusetts is in itself an amazing example of how this idea of community health workers is not unique to India. It's been actually implemented in many parts of the world. And ironically, it's also there in the US. except that it's a little bit under the radar. It's not part of an organized healthcare system. But I'd love to hear Paul's last words actually on the PIH model. But the reason why it wasn't foreground in India is very simply a question of power. At the time when the pandemic was exploding in the north, the entire narrative was hospital-based. The entire narrative was about doctors in white coats and ventilators. I mean, it's easy to forget today that ventilators are actually being downgraded. We don't even talk about them because, it's like probably not a good idea. But back then in February and March, if you remember, it was all about how many ventilators did the city have. And countries like India were absolutely mesmerized by the idea of ventilators. And I remember very well the kinds of experts the government of India called on board were people who'd never stepped out of a mass gen kind hospital. When actually what you needed were people on the ground, boots on the ground, understanding how epidemics spread in societies through human contact. And of course, that's what we're doing now, but far too late, unfortunately. But Paul, I want to end with hearing about how PIH's model has been used in Massachusetts. Sorry, Michelle, I just thought that's a really wonderful way of taking the community health worker movement back to the US.
Absolutely.
Well, just to make a short comment, many groups, as Vikram have said, have been pushing forward the idea of community health workers in the United States for long years, for decades in any case. It has been a very discouraging kind of activism because it's quite clear that we can't deliver care for chronic diseases without the help of community health workers. There's abundant evidence. Every study of this shows pretty much the same thing. You improve quality care, you reduce expenditures. So the powerful incentives aligned against it are just the kind of structural impediments that Anne discussed in her comments and have been brought up every time. Our best PIH experience has been in Rwanda, where even then it was a very controversial issue. Why? Because the international financial institutions had developed in the 70s and 80s structural adjustment programs, which said you have to decrease public expenditures. So radically enrolling, upscaling the public employees is a no-starter in most countries unless they have extreme independence from the international financial institutions like the World Bank, the IMF, et cetera. And Rwanda did buck that trend. And within the space of just a few years, went from having very few community health workers to over 50,000. And this is in a country of 11 million people, quite small. I mean, would fit into the pocket of a big Indian city. And you wonder why they've had more success than we have in terms of keeping their borders safe with minimal lockdowns, contact tracing, defying 2 border epidemics of Ebola just in the last 2 years. They have the personnel to be on the front lines, and I think we have a lot of lessons to learn from what they've done with such tiny amounts of resources and applying that in the United States, Rwanda specifically. And we did that in Massachusetts. Again, Governor Baker, who I didn't really know before this, was an ardent supporter and very unhappy with, he almost said containment nihilism, So that was it's always good to find supporters, maybe sometimes where you don't expect them.
Yeah.
Thank you, Vikram, for letting me say that.
Yeah, that is terrific. And I'm sure that Trump would be very impressed if we told him that he has something to learn from Rwanda, but that's another story. So unfortunately, our time is up, but I want to thank all of you. I think you were absolutely terrific, and I hope that many people will take time to watch this, and we'll circulate the link, of course. And I want to thank our audiences. We are left with a great many unanswered questions, 18 of them on the screen, but hopefully in some ways the comments will have answered some of your questions. So thank you, and I really, really appreciate that you took the time. I want to invite you to the next event, which will be on October 7th, and it's a panel that is organized in honor of Coming Out Day on transnational queer solidarity. And one of Arthur's colleague, George Miu, will be there. It's a panel that is co-organized with the Georg Simmel Chair at Humboldt University. So please mark your calendar and join us then. And thank you, colleagues. I look forward to seeing you in person one day soon, I hope. And I appreciate Anne joining us. And thank you also to the Weatherhead staff for their extreme competence in bringing us together.
Thank you, Michelle.
Have a good
Thanks,
afternoon.
Michelle.
Bye-bye.
Thanks, everyone.
Bye, guys.
Good to see you all.
Bye, Alan.